Okay, so my talk is going to switch gears a little bit from the other two, and instead of looking at a specific technology or software, trying to give you guys a overview of the landscape from a more clinical perspective, using brain tumors as an example of how we're in need for help with applying some of these more advanced tools in machine learning and deep learning in various aspects of patient management. So I'm going to give you a quick motivation of primary brain tumors. As opposed to a few years ago where there were only 15 to 20,000 new cases a year, in the last 5 years this number has risen drastically. Gliomas comprise 80% of brain malignancies in adults, and they're the most common solid tumor in children. They're also the leading cause of cancer death in the age under the age of 20. Symptoms are usually caused by one of two mechanisms, either a mass effect or increased pressure from the tumor itself, or infiltration and destruction of normal tissue. Seizures also occur in 20% of these patients. There are various types and grades of glial tumors, which are the second most common. And the higher grade of these tumors are more malignant, meaning they are more aggressive, infiltrative, proliferative, hypoxic, and angiogenic. So this means we need to find markers that can identify these characteristics. And despite the numerous drug trials that have existed over the last 15 to 20 years, the conventional therapy is still surgical resection followed by external beam radiation therapy and temozolomide chemotherapy. And with this therapy for the highest grade glioblastoma, survival is still only 15 to 18 months. So where does imaging play a role in all of this? The triangles here show times in patients' management where imaging is performed. So as you can see, there are a lot of these triangles in this diagram. Before surgery, between surgery and radiation and chemo, serially, if you have a high-grade glioma, you would be followed up every 2 months. Then at the time of progression or recurrence, then you would be scanned again before another possible surgery. And then usually there's some sort of clinical trial, new agent that you would go on after recurrence. And again, the monitoring even would need to become more frequent at this time. So this is an overview of the different roles that imaging plays in the three main areas in my opinion. So you can use imaging for lesion characterization, looking then at response assessment to therapy, and then the longer term therapeutic effects on the normal brain. And I'm going to try to go into each of these a bit. So for the first challenge is with the lesion characterization is spatially these lesions are very heterogeneous. So you can see from just standard anatomical weighted imaging, anatomical imaging that is used clinically, you have here a T2 lesion that is very heterogeneous and contains edema plus infiltrating tumor. And it's impossible to know from this lesion, from this image, where one ends and one begins. Then there's also what's known as the active tumor, which is the area of where there's contrast enhancement in this T1 weighted image after you inject contrast. So there's no clear boundaries, so determining the tumor extent is difficult. And they're also infiltrative, so microscopic disease can exist beyond and extend beyond even the edema region. Also, there's heterogeneity within and among tumors. So among tumors, here's an example of different grades where you can see that a grade 3 tumor, for example, some of them may look like grade 4, some of them may look more similar to grade 2, and even within a grade 4, there's various presentations that ranging from what looks like it could be very low grade with a longer survival and more malignant, this necrotic center here would be indicative of a worse lesion, but it's not necessarily the case. These all could have different outcomes. So what are even though these standard anatomical imaging are used as the criteria for prognosis and response, there are several limitations associated with it. So I'm going to try to go through this fairly quickly with the intent of then presenting how more advanced imaging can be and should be used. So contrast enhancing only reflects what's the blood-brain barrier breakdown. It is not actually indicative of tumor cells. So it's usually indicative of increased grade or tumor progression, but it's not at all specific, and it's not quantitative. It can also be found in necrosis, irradiated tissue, and pathologies that have nothing to do with tumor, like toxicity. Then the TEAP2 lesion is a combination of edema and infiltrating tumor. So not only is it difficult to determine tumor margins, but the contrast is affected greatly by your sequence parameters of choice, and then the therapy itself can also induce edema in otherwise normal brain. So we want to be able to incorporate other metrics into the standard anatomical imaging. And now, over the last several years, in the clinic, diffusion-weighted and perfusion-weighted imaging are types of physiological imaging that are now integrated into a brain tumor imaging exam. And from these, we're able to quantify a lot more parameters now, mostly representing blood volume and vascularity, the amount of fluid and cellularity, how much cells there are, and then in more of the research setting, not so much adopted clinically yet, but we have metabolic information that can be used to look at cell turnover and hypoxic areas from the presence of lactate. So we now have more tools. Going in a little bit more deeply, what for spectroscopic metabolic imaging, what you can actually see from this is that you have, in normal brain spectrum looks like this, where you have choline as a marker of cell membrane and cellularity, creatine is your cellular energetics, and NAA is normal. So as you would expect in tumor and necrosis, this choline would increase with more cell turnover and cell membrane breakdown. The NAA, your normal neural function, would decrease, and lipid then could also be present, as well as lactate. And that would indicate necrosis and hypoxia, respectively. We then typically quantify a measure of aggressiveness using the choline to NAA index. Basically, it's created from plotting all normal and abnormal voxels from the whole, as much of the brain as you can acquire. You do an iterative approach that then removes voxels that are above 2 standard deviations. You keep applying this to get your normal regression line, and then the distance to this line would then be your CNI index, which the further away from your normal would be your CNI index. So it's a good measure for automatic quantitative measure of metabolic abnormality. And it's been used to show spatial heterogeneity, as well as looking at the levels of lactated lipid. So we have a bunch of imaging metrics, and in the literature there has been a lot of papers that associate these metrics and others with different cell properties and pathology. But most of these, unfortunately, are still in smaller studies, and they have not been combined across using all of them together to gain a big picture of aggressiveness. So then if we move on to diagnosis, that we usually have molecular markers, tumor grade, and cell type are what goes into how a tumor is diagnosed. The molecular markers is only very recent criteria, but we've been able to have markers from imaging that have been able to look at diagnose based on grade, tumor type, when you can create maps of this, which is useful to then guide where to sample tissue from to take biopsy. And then more recently, I don't know if you can see this, but the molecular markers, IDH has become, plays a big role in determining how, instead of tumor grade, if it's IDH wild type or mutant, how a person is going to do. So there's been new markers that have been developed that are downstream byproducts of it, such as 2HG using spectroscopy. And then And then the goal is to often use these maps that you can generate to help guide diagnosis. And if you can, again, help look at where to sample tissue from to be able to make the most accurate diagnosis. And what I found interesting is recently there, 2 months ago, a paper came out to be able to use different deep learning on standard anatomical imaging to predict IDH status. They used about 500 training data sets, which for this field is actually quite a lot to get a hold of. And using the combined anatomical imaging, 2 types of T2 and pre and post contrast T1 weighted images, they were able to get a better prediction accuracy. Still, other molecular markers have not been investigated yet. This is only the first one of this type to come out, and it only was 2 months ago. And we need to incorporate other imaging. We have an array of physiological, at least imaging, that is routinely done clinically now, and how is the best way to incorporate this, and what is the best network. So then the last part of, in terms of lesion characterization is in terms of outcome. Right? So what we really want to know based on your diagnosis and the spatial heterogeneity is how a person is going to do. And here's an example of 3 different people with all diagnosed with a GBM, or the most malignant grade tumor. And you can see they, from anatomical imaging, they look quite different. And maybe what you would expect in terms of what appears to look worse isn't necessarily always the case. So where the person on your right looks like less messy, less necrotic areas, they actually ended up doing worse and dying within 6 months, where someone who has a larger tumors actually were stable for longer. So there's a lot of variability in survival, and we want to find non-invasive measurements to have markers of this. Our group and others have studied predictors of worse survival at various time points, both before surgery, and found different parameters that have been associated with survival. Most of these methods so far have all used statistical modeling and mixed effects models. The idea is to move this into using more machine learning. And then before therapy, what remains after surgery is actually more of an indicator of poor response, because if you can imagine, if you take out the worst part, then that's no longer a predictor of survival. So some new parameters become relevant. And then you can also look at serial predictors of response to therapy. But as I said, there's still a lot of limitations remaining with this. So we have not only the most spectroscopy, or the metabolic imaging is really the most specific to date, yet at the same time it suffers from the lowest resolution and the worst coverage and the most technically difficult to acquire. So it would be helpful to have things like super resolution to help make this better to compare with the other imaging modalities. Also, many of these studies, they're often use a single imaging metric to outcome or whatever diagnostic classification. These studies usually are performed in small cohorts of less than 50 patients, and within lesion level metrics and radiographic response, rather than directly relating to pathology. So your outcome is often based on this response criteria of the anatomical imaging, which we know is limited in itself. And because it's harder to get direct pathology all the time. Some studies have also began to combine certain sets of markers to associate pathology with outcome, but it's hard to get enough power and data sets to combine so many parameters. And we lack voxel-wise predictions, as well as independent test data sets for validation. And to date, still most of the deep learning and radiomic studies that have been presented still use for anatomical imaging. So there's a lot more we can do here. Okay, so response, the next category is challenges with response assessment. So the first part of planning for radiation is actually determining where to deliver the dose. So defining tumor margins, you have no clear boundary of where the actual tumor is, and it requires a voxel level, not just lesion level analyses. So we have tried to use the data from metabolic imaging along with diffusion and perfusion to be able to come up with a map that predicts before radiation to then predict where recurrence is going to occur. And knowing then, if we can know this beforehand, we can then plan the radiation therapy to include this area that wouldn't otherwise be included because it is not visible yet on the anatomical imaging. And right now, radiation therapy planning is just purely based on an equal geometric expansion of the anatomical lesion. So the goal is to be able to have a modified dose based on to include this area of where recurrence ends up, so prediction, and then we created our initial prediction maps based on just statistical modeling, but we want to be able to use more of the features represented in the whole tumor to do deep learning, to do these sort of analyses. And then the other component is monitoring response. So we need to have a good estimates of lesion volume, and then also take into account ways to recognize pseudoprogression and pseudoresponse. And I'll explain in a minute what those actually refer to. So most of you probably saw Peter Chang's demo on Wednesday afternoon with the challenges in segmentation and lesion volume. Every year there is a challenge known as the BRATS challenge for segmenting brain tumor lesions based on the T2 and T1 weighted pre and post-GAD anatomical imaging. The segmentation is important for two different reasons. One, you want to be able to assess small changes over time, so see how a lesion is growing. More accurately, you can do that. And then the other is that you want to actually be able to look at what's going on in these lesions. But in the last, some of the limitations inherent in this is that the data sets that are used in these challenges are often limited, so that you have different sequence parameters affecting the contrast. So when you go beyond the certain data set and apply it to other institutions, the results often fall apart. You have different field strength scanners. You also have all of these data are based on your pre-surgical, before any treatment is applied. And then, realistically, most of your data is actually going to be after surgery that you're looking at. So, how does then that handle when there's a cavity, when the contrast and the lesion itself changes after therapy? And then you also have a lot of inter and inter-rater variability in generating these labeled data sets. So then this could highly affect the accuracy of what you're learning. And then there's often this disconnect between the algorithm development and the clinical utility, as well as still limited sample size and data. So moving on to pseudoprogression, in monitoring response after radiation, there's often this increase in your lesion on contrast enhancement, T1 contrast enhancing images, because of the therapy. But this then, if you wait a month or two, this will often resolve. So knowing what's pseudoprogression versus true progression can be important, because you don't want to take someone off a therapy that then would be beneficial to them. On the contrary, you can have pseudo-response, where you have something like an anti-angiogenic drug which normalizes your vasculature, so your blood-brain barrier now is not leaky anymore, which is the marker that you were using to define the tumor to begin with. So if you take away your marker, now you need other methods of response because now you have a pseudo-response due to the therapy itself and not due to the actual tumor. And if you look at, this is just an example of how this can affect different parameters that you would measure from different images over time. And depending on the drug that you're given, whether it be the combination on the left or the right, you can see how the lesion changes over time can be drastically different. And the same is true for other, even diffusion parameters as well. And then this is an example of your metabolic CNI map that I explained before, where when you have your, this can be used to maybe increase your specificity in these challenging cases, because this bottom row where the T2 lesion appears to actually get bigger over time, but the metabolic lesion is shrinking. Or conversely, you have a region of T2 lesion that seems like it's stable and the person would be doing fine from this, but then your metabolic lesion is actually growing at this point. And then the last part of the challenge and response assessment is when it comes to the time of progression. So at this point, you need to, if you suspect progression, right, you need to know whether it's recurrent tumor or the effective treatment, whether or not the person has upgraded in their actual disease status, like if they started as a grade 2 and now it comes back as a grade 4 rather than just getting bigger as a grade 2, and then if there's any hypermutations associated with the therapy. And we've done studies to show that you can use imaging to predict malignant transformation, and this is really, and it's correlated with histology measures of it. And then you can also see, this is an example of a person who comes back with this new lesion at the bottom part of the brain, and it's due to treatment of chemotherapy-induced mutations. And then finally, here is, we lost the one graph. The point of this slide is just to show that the other area then is gliosis mimics recurrent tumor. And the challenge here is that people often assume that a patient either has tumor recurrence or has gliosis or treatment effect. And you don't want to send someone back to surgery if it's not necessary. But often, in reality, you don't have one or the other. You have a mix in the lesion. So spatial heterogeneity and determining where to sample to make sure you get the area of recurrent tumor versus treatment effect becomes very important. And you have also, in doing these studies, the sample size for the treatment effect or pure treatment effect to be able to then train models to do predictions is limited, because you're always trying to go for where there's more aggressive tumor, if that makes sense. So as the challenges that remain for all of these is that each new therapy requires a new set of markers. Drug companies typically don't build and target specific imaging to the trial, so it's hard to get this data until you do research studies, and then it can often be too late. And how do you get enough data to combine all these parameters into prediction? And then the last part I wanted to focus on is the bulk of my research in the last few years, which has been on looking at the long-term effects on normal brain and normal radiation therapy on normal brain in vascular injury especially. So radiation has been shown to lead to impaired cognitive function, and it can affect all areas of the brain, but I'm going to focus here on the microvasculature, and both from an arterial standpoint and venous in terms of vasculopathy in the form of microbleeds. And the location of these microbleeds can often depends on the dose received, but then there's also some regions of the brain that are more sensitive to others. And how do we use then imaging metrics as surrogate markers to assess damage to different parts of the anatomy? You can do an array of MR imaging tools for assessing radiation imaging and radiation injury. I am going to focus on our vascular phase-sensitive SWI and MRA, so looking at veins and arteries and microbleeds. Why do we want to look at microbleeds? We've seen that they've increased over time with these lesions. In children, they can appear even earlier and have more of an effect on cognition. They continue to increase in numbers. Sometimes their size will increase at first, but then over time they might disappear again. They reflect a spectrum of vascular injuries, and they're not only unique to RT, there's a lot of other diseases such as Alzheimer's and cerebral cavernous malformations that have these lesions as well. Traumatic brain injury. Then there's they've been associated with worse executive function and working memory. So we have a protocol for a strategy of how to relate vascular injury to cognition, but I'm going to focus on here our automated algorithms for CMV detection and segmentation of the vasculature. So we have a sequence that we can look at both the microbleeds, vessels, and then the arteries at the same time. But these images need to be processed to be able to make meaningful quantification. So we have, because these are required with the same sequence, you can actually overlay them without any registration. Here's the white is the arteries and the dark is the veins and microbleeds. You can see them on your screen as well. So we want to look at their origin, if they're coming from the veins or the arteries. We want to be able to look at their distances from veins and arteries, how the vessels around them narrowing, if there is a difference between gray matter and white matter, and how this explains how quantifying them can relate to differences in cognitive function. You guys have seen a lot of vessel segmentation in previous talks. So the challenge for us is that we want to be able to maintain accurate vessel thickness while at the same time being sensitive to small vessels. And the common Frange filter with even modified thresholds still can often lead with missing areas compared to manual segmentation. And it's not flexible to different thicknesses and projections. So we don't want to always have just a 2D maximum intensity projection through all the slices. Sometimes we want to have control over that depending on what we're looking at. So that made us come up with a modified method where basically we include a measure of vessel thickness through Euclidean distance transform in selecting the scales to put into the Hessian filters. And then from this, we were able to achieve a good segmentation of arteries as well as a map of vessel thickness. And this is just a comparison. Still can't see the smaller vessels on this projection, but believe me that they're actually detected, whereas the original scale one, they're not. It works for various various projection thicknesses and compared to manual segmentation. And then the other area that we are interested in developing or have challenges in looking at the actual microbleeds. So they can often be difficult to discern from perpendicular vessels. So here's an example. You have two little dots here that are microbleeds, or that could potentially be microbleeds. If you scroll through the slices, you can see one actually stays stationary and it's a true microbleed, while the other is a perpendicular vessel. You also have the problem that some patients can have hundreds of microbleeds, which is far too many to count and keep track of manually. Their size can vary from 1 to 10 millimeters, and manual delineation is not only extremely time-consuming, but extremely prone to error. So we've spent some effort in the last few years developing methods to automatically detect these using just basic image processing methods, which have initial detection step and then use the empirically derived features that we know of inherent to microbleeds to reduce false positives to get your final mask. The goal was to optimize on sensitivity here because it's easier to remove microbleeds that are not real than to go and try to search for new ones that you miss. So we had a highly sensitive algorithm, but we missed with very few that were missed, but then we ended up with a large number of false positives. And that became the challenge. We have high sensitivity below specificity, and we needed to come up with a way to remove the false positive mimics. So we developed a GUI to basically ask questions about potential microbleeds that could be mimics, and then it has an interactive user to actually go and label each of them. And this then results in a summary. It creates a segmentation of the volume, and then also creates a summary of different feature characteristics of all your microbleeds, including and your false positives. So we can then put them into a deep learning algorithm that basically takes every candidate or potential microbleed as the center of a patch, and then puts it through the network to be able to say whether it's a false positive or a true microbleed. And we train this on about 100 patients with several thousand microbleeds this way, and even more false positives. You had to do all sorts of data augmentation, and in the end, we're able to greatly increase our specificity. And now we're only down, where instead of having 50 plus microbleeds, or sorry, false positives per every patient, we're now down to 10. The result of this, and if you look at regions where the algorithm, the network failed, it's actually very hard for a human to even determine whether or not it is a real microbleed or false positive. So we have these likelihood maps that are also generated as an output, so it can give us confidence to how much we think that they're a microbleed, and this could be helpful with serial then assessment of them to look at if something's there before, how much confidence gives it to be there later on. And then we're trying to also incorporate other types of disease into these microbleeds and larger lesions into this network, and being able to segment them as well. And I'm going to end here with some things to think about for common challenges that are present across all these diseases. So we have image registration and tissue shift is always a problem. We have different resolutions of techniques. We have standardizations that, across different sites, pre-processing, how to normalize. You have to, in transitioning from lesion level to voxel level analyses in order to address spatial heterogeneity. How do you determine what's enough data to use in a CNN? Is the accuracy of the rater or labeler worse than the network? And then, to me, most importantly is, so we have these tools, and they're used in the research setting, but how do we actually deploy them reliably for clinicians to be able to have confidence to want to use routinely? So with that, if you have any questions, I'm sorry if I took a little bit longer, and thank you.
That's a great talk, Janine. I'm very curious. One curiosity is, how can you pull apart protein deposition and microbleeds? Is there any chance that those two things can be confused? When they're, because we've heard of protein deposition is one of the things used in neuropathology to detect, to associate to Alzheimer and whatnot, like tangles. And I have no idea if there is a shape, a way to put them apart, or the scale is completely different. Do you have any thoughts?
They're completely different modalities that are used to detect each of those things. For the microbleeds, you're looking at hemosiderin deposits, so you're not going to detect, you can't detect the amyloid and those things with this type of imaging. You're looking at iron and blood deposition.
That's perfect. Yeah, nothing better than the expert to tell us how it is. Any more questions? Okay, so I would like to thank Janine again for coming to ImageXD, and we're a little bit